Thank you for the invitation again to this amazing platform, which we want to share with all of you two interesting cases of what I call a rare pathological condition on the spine. But I think we as spine surgeons are we in the obligation to know who they are, how to treat them. So first we can bring these patients back to their labor force or to their own activities, but at the same time also we don't hurt them. And this is part of the mission for us. And so not only wanted to share with all of you, see what your thoughts about this, but also what else can we do to make this patient population better. So specifically, we're going to present a peripheral nerve tumors on the sacral area, which, as we know, they are a very rare conditions, and even more rare when they reach the size that is surgical um, uh, indicated for their treatments. And which is interesting is always the first thought is that we are dealing with a sacral chordomas being the #1 tumoral lesion there. But once you know that it's actually not a chordoma, it opens a brand new windows of opportunities for the patients and for us. So just going to keep going and let the coordinators or the moderator, Dr. Geyer, Ziegler, or Chapman wants to add something, we would like to proceed with the first case.
So no, go ahead. Yep, okay. Go ahead.
So we have Dr. Morgan, one of our fellows in here at the Barrow Institute, that is going to present the first case.
Hi, everyone. My name is Clint Morgan. I'm a current 6th year Dr. Uribe's enfolded fellow at the Barrow. So we're going to talk about the first case here is a young cardiologist, relatively young, about 55 years of age, who came in asymptomatically with one of these nerve sheath tumors. So past medical history for this gentleman: hypertension, hyperlipidemia, no real cancer history in himself or his family. And again, he came in neurologically intact. This mass was found incidentally. He also had normal sphincter tone on exam. As I mentioned before, he's not only a cardiologist, he's an interventional cardiologist and very much active in his practice. So in terms of imaging that we initially had, so pre and post-con imaging here. So looking at the post-con imaging in the sagittal plane there in the second panel, a large mass arising ventrally
use the pen
from the, here we'll use the pen there, from the sacrum here. Here we go. Okay, we're gonna switch over to a different color here. There we go. So large sacral mass, and on the inset view, what we're trying to show is that this is indeed a contrast enhancing mass. Now, as Dr. Uribe mentioned, we frequently think of sacral chordomas in this region as arising here, and certainly of most concern for him. And interestingly, on T2, it is T2 hyperintense. So we move to on the CT scan. This is how things look. So looking just ventral to the sacrum, you can actually see some scalloping edges of the sacrum here. Here's an axial view as well, but you can see that the mass itself is not calcified in any way, but has remodeled slightly on the ventral sacrum. So next steps is really thinking about the differential diagnosis for this physician. And of course, as Dr. Uribe mentioned, chordomas are a concerning pathology that we all think about in this region and are the most common really in this region. So chondrosarcs, Ewing sarcoma, osteosarcoma, and giant cells. And obviously have to think about metastasis in any instance like this. And as we're discussing today, also the consideration of nerve sheath tumors like schwannomas, neurofibromas, or MPNSTs. So what do you do next? So this is, again, a 55-year-old gentleman. He's very active in his career as an interventional cardiologist, but he's asymptomatic. And, our goal is to really take care of him, but not make him any worse for the wear.
Bring him back to work.
Okay. And definitely bring him back to work as soon as possible. So what is our plan? So do you want to proceed with observation? Do you want to try biopsy first, or just go straight to surgical resection? In our case, we had a long discussion with the patient and decided to proceed with a CT-guided biopsy. And this pathology came back consistent with a spindle cell neoplasm, consistent with schwannoma. This is just a generic H&E of what these typically look like, if you all recall from our boards, in these Antoni A and Antoni B regions. And his was particularly rich in Antoni A regions, and also had a low MIB on his replication index. So going back to discussion with the patient, decided to proceed with surgery, knowing this was most likely a benign schwannoma. We could likely achieve excellent resection. So we coordinated with our plastic surgery colleagues, neurosurgery co-plastics, and proceeded with the case. So we monitored sphincter EMG, SSCPs, and basically did an S1 to S4 laminectomy, used the bone scalpel. Dr. Uribe is fond of using for our laminectomy here, and then distally amputated down around S4, the sacrum at that point. Once the laminectomy was completed, worked around the...
Yeah, you can go back to the MRI.
Oh, sure.
So what is the, one of the interesting things is he showed that the origin of the tumor on the MRI, that, showing that.
There you go.
Yes, you just keep going, just showing what the origin is.
So you can see, clearly on the MRI, this seems to be arising from the neuroforamina, arising from a nerve root itself. I'm trying to draw there. Okay.
You have to get into
Pin mode. So this was suspicious just on the initial imaging for being consistent with a nerve sheath tumor. So working around, key with these benign schwannomas is to really identify the pseudocapsule around the tumor and work around that pseudocapsule and sort of use that natural plane to divide along that pseudocapsule. Yeah, so we also use the ultrasonic aspirator to centrally debulk. Really worked, from a posterior position to kind of work anterior, then posterior.
Yeah, right? But and the first question is to decide, how you would like to approach this tumor. You want to do a anterior and posterior approach, or just posterior? Can you handle everything posterior? And that was part of the thought, correct?
Mm-hmm. Correct.
So just walk it through why we decided to go only posterior and not anterior and posterior, and what was the point? And you can.
Yeah. So in this case, we really thought we basically wanted to preserve this gentleman's function as much as possible, and with a partial sacrectomy, we were able to. We thought we'd be able to achieve that. And we didn't need to have, like a complete en bloc resection like we would need for a chordoma, for example. Anything else you want to mention on that?
Yeah. And then also from the posterior part, it was a good possibility that actually the tumor can be accessed. And since the tumor was not really in contact with vital structures anterior, which means like big vessels, or and then knowing that it's a benign condition, obviously you want to have a gross total resection, but sometimes we err into do a subtotal resection, knowing that it's a very slow growing lesions, and be able to bring patient back, trying not to get the sphincters compromised or any motor function compromised. Mm-hmm. So that was the main idea. Obviously you always want to obtain gross total resection, but in these cases, you also have to be on the side that the patient will have a good outcome.
Yeah, and we knew in this case the patient's replication index was 1% or less from his preliminary pathology. So after central debulking, working around the pseudocapsule, performed a S4 neurectomy on the right side. being very careful, as Dr. Uribe alluded to protecting the adjacent sacral roots there. At that point, once we felt like we had achieved a good resection, we had our plastics colleagues come in, and really all that was required in this particular case was a bilateral gluteal advancement. And so they assisted with that. And then we basically left a drain with kind of the normal plastics sort of considerations in this region, so near to high risk for infection in these cases. And so very careful with that and with sort of hygiene in the postoperative days. After surgery, the patient was remained neurologically intact. He was 5 out of 5 strength and normal sensation. For the first day or so, had a little initial difficulty with urination, monitored PVRs in the floor. Never required catheterization. We did have urology follow him while he was inpatient. So, looking at our pre versus postoperative imaging here. So this is pre and post-op comparison in the sagittal view, trying to achieve the same slices here. So you can see a nice gross total resection. You can also see, even on the MRI, the sacral amputation. And again, an axial view of the same just down below. Looking at the post-op CT, this really shows the extent of the laminectomy from S1 to S4, and then the distal sacral amputation. Again, consistent with the initial CT kind of biopsy, the permanent pathology confirmed schwannoma with a low MIB. So we just saw this patient back about a week ago, I think it was, for a 6-week follow-up. Remains neurologically intact, basically begging to go back to work. And so he's healing up well and has all of his drains out. We actually discharged him with his JP drain just to collect any extra stromatous fluid over time. And so overall, a great outcome, and continuing to follow up with the plastics just to continue monitoring his incision.
This was the first case. I wanted to know if you have any comments, any questions, any suggestions, and before we move to the second one, that is a little bit more challenging itself.
Juan, this is Izzy Lieberman. You mentioned that the patient presented asymptomatic. What was the decision making to actually put him through this then? Yeah. Why not just monitor him?
Yeah, so what happening here is, and this is actually a long decision making easy. So this patient actually, the first question is how he got diagnosed, yeah? Why he ended up doing that? So this gentleman works as an interventional cardiologist. He started feeling a little bit of discomfort on the low pelvic area. So he decided, as cardiologist, who knows, to do his by his own, like an ultrasound or something. And they say there is something on the pelvis. So then that called for the MRI. And then he got the MRI, and then boom, that surprise of this tumor. And then he obviously, as you know, when you're a physician, we know too much. He started asking a lot. And at some point, he was afraid that if the tumor was continue growing, 2 things which all come to most of the people's mind. One is, what is the chances that this can convert into a malignant lesion? We know that is small based on the pathology that we have, but it's not zero. And the second one that he was a lot of concern is, if this keep growing, if the surgery will be more complicated when it gets bigger than it is. So our answer was, yes, the chances of malignancy is very low, that I don't think justify, but definitely trying to do a good resection now that is more manageable, the morbidity of the procedure will be less, more chances to preserve the sphincter, so on, and the other functions. And he decided to have the surgery, I would say like that, easy. And the challenge was that, how can we bring this guy back to work, yeah?
Juan, you said you used the ultrasonic aspirator or the to debulk it. Did you get the entire capsule out, or as much as you could?
Yeah, so when we do the schwannoma, Dr. Geyer, we like to open this, the main capsule, and then it has a little pseudo capsule that you start working that plane. And to be honest, my initial plan was not a gross total resection. But which was interesting is once we amputate the distal part of the sacrum, like an S4 down, and start working around the pseudocapsule, that actually it seemed like the rectum or the colon start pushing the tumor towards me, and we were getting more and more, and suddenly we keep resecting. At some point there were no tumor anymore. I mean, it actually was easier than expected, and then the outcome was very good. But definitely he had a really good plane. That's what helped us out. I think we were able to find that pseudocapsule, and then at the end, actually the whole tumor came back, and we just saw the rectum on the front.
And so you only had to resect the S4 nerve on the right. So he had no deficit whatsoever?
No, it's amazing. At the beginning, he has some folly, but then the patient basically get out of the hospital pretty much with no folly, no nothing. And he's actually having full sphincters control, which is very interesting. It's a couple of manuscripts. Most of them are led by Dr. Gokaslan, at the previous John Hopkins jobs. And they say that if you're able to leave some of the lower sacral roots intact in one side unilateral, they may help to prevent sphincters, dysfunction. And, obviously, we always try to protect as much as we can. And, in this case, we were able to leave, the roots in one side almost intact. So that one helped, very, it's good because what we're happy is because with the objective that was bringing him back to the labor force was, obtained, and the resection was very good. Obviously, as we mentioned at the beginning, these are very rare cases, and the volumes are not there. So each case becomes for each of us like a big personal experience, But I think we were thinking it's good to share with all of you, because if somehow you have one of them, you may remember this case where we're actually achieving gross total resection without coming from the front. And when we presented in our grand rounds in here, some of the attendings were actually promoting I can go front and back, which is a much morbid procedure. Somehow, if you go around, you get the small sacral amputation and you start dissecting around it, actually you can have really good access to the tumor without compromising, abdominal structures.
Yeah, and Juan, that was somebody's question in the chat. They said, why didn't you go anterior? Or what's the rationale for not doing it? I think you just explained it.
Yeah, and then also, good friend of mine, Dr. Dan Shuba, you guys know him. I was also, checking with him before the case what he thinks, and he gave me a really good point. He said that as long as the tumor is on below S3, most of the time you handle it posterior with no problems. You can handle it. When it's higher than that, that's when you start more like, let's do front and back. And the problem, as you know, addition of the anterior route, the comorbidity, the morbidity of the procedure goes double at least. Yeah.
Great case. Yeah. Send him to Dr. Uribe.
So we're gonna bring it to now Dr. Katzman. So this one is a little more challenging because you will see the difference between the first case and this case. This one is a little more challenging, but again, this one also has a very close similarities to the chordomas or the chondrosarcomas. Okay, Dr. Katzman, your call.
Hi everyone, Gene Katzman, PG White 8 now, I'm Dr. Uribe's fellow. I'm excited to be here. Thank you to SSF and Dr. Uribe for the invite. So this is another interesting young, healthy patient, 25-year-old healthy female. She presented with progressive, debilitating back pain that radiated into her lower extremities. She did not have any paresthesias. However, the pain did interfere with her sleep, and the pain was so debilitating over time, she lost about 40 pounds. So very thin by the time of surgery. Otherwise, no significant past medical history, no cancer history. And when we saw her, she was neurologically intact, full strength, and bowel and bladder intact. So again, starting off really, really in good shape. So you have to be very decisive about your decision-making process. And so this was the imaging that she had. You can see pre and post contrast axial images. You can see the heterogeneous enhancement. It definitely does extend more to the left towards the SI joint, and it did enhance and encapsulate several neuroforamen on that side. Not as much towards the right, and we were able to preserve those. Like Dr. Uribe talked about, the unilateral, preservation may help. And then the sagittal cuts right there. You can see with contrast, significant large sacral tumor going up to as high as S1 with the large ventral component. And here again at T2 images on the far right, you can see the T2 signal compressing the thecal sac down near the sacrum. There was a good fat plane between the tumor and the rectum, however, which would help down the line. This is a CAT scan, and here you see the significant bony destruction of the sacrum and the large tumor essentially. And again, on the axial cuts, you see it's more involving the left side of the sacrum, involving those left foramina compared to the right. So going into the management, like Dr. Morgan talked about, there's a wide differential diagnosis. So one of the first initial steps, what you want to discuss is, what's the tumor and what will your plan be to address this tumor?
Yeah. And again, in this case, this was, again, very challenging. Is a very functional person. Actually, this female used to work in Costco, one of those big, large stores. And she's, beside the pain, she was functioning good. NAS sphincter dysfunctions, 25-year-old, already with 2 babies. And so the question is, at that age, with that bone erosion, with all that changes, when you go over the differential diagnosis, obviously the first thing comes to you is not actually a schwannoma or neurofibroma. So this one comes easier, like a giant cell or a chordoma, which is most of the diagnosis. Just keep going.
So that was the concern, was it a chordoma? So first step in the whole decision-making process was to do a needle biopsy, and you can see here needle going right into the center of the mass. And this was a strategic trajectory near the center. You don't want to go off from the side, because if it does turn out to be a chordoma, you want to be able to resect that biopsy tract. So a patient underwent this biopsy, and it turned out to be a schwannoma with epithelioid features. And so at this point, given the amount of destruction and the large size of the mass, its mass effect, its effect on the patient's health, she was essentially losing weight because she can't move because it hurt so much. So at this point, even though it's a schwannoma, it was big, it needed resection. And something like this, it necessitates a large multidisciplinary staged approach to resection, lots of different teams involved. So neurosurgery, for example, there was both the open surgeon, Dr. Uribe, and the endovascular surgeon, who would end up embolizing, and I'll show pictures for that. The plastic surgeon who would assist in the approach and the flap. The colorectal surgeon who ended up mobilizing the rectum, for example. Obstetrics and gynecology that ended up doing a hysterectomy just because the patient wasn't planning to have any children, and there were fibroids on her uterus, and to benefit our approach. And then finally, again, vascular surgery to help with the approach and to further our resection.
Yeah, so, and then this is an important point right now that if you're considering approach this type of tumors, you have to assemble a really good team, and the team, everybody needs to know what is his role and make sure that everybody functions. So as you see here, we have 5 different specialties just colliding in one single pathology. But I think this is one of the good examples when each one bring what you're the best for, and then trying to improve some patients' outcomes. So you have to have that, and if you really don't want to have a really bad run, or you don't want to end up in a very suboptimal surgical outcome.
And this was planned over several days, perhaps a tumor board meeting. This is not something you just add on for the next day. So this was all very deliberately discussed. And it's a slow growing tumor, so you could always potentially do it as an outpatient in a week or two. So the first thing is that, patient already had a biopsy proven to be schwannoma. So then the next plan was to do a preoperative embolization. And so on the left here, you see the tumor blush. And on the right, you see the post-embolization radiographs after injection of onyx.
No, it's not that. You have to go to the little pen on the left.
I don't see it here.
No, it's on the left. It's right there. It's a pen.
I don't have it on my screen. So you can see the onyx, post-onyx embolization radiographs here, and this was all to assist to make surgery less morbid, less blood loss, etc. So surgery here, given in contrast to the first case, much more anterior tumor and much more superior tumor. So the approach here was going to be two-staged. First, it was going to be an anterior approach, and then come back the next day and do a posterior approach.
The objective was trying to get a gross total resection, not an en bloc resection. That would be a different game if there was, for example, a chordoma, which makes our life easier, when you're not shooting for en bloc resection, which is a way more complicated and morbid procedure. Yeah.
So, first day, vascular surgery, plastic surgery, do the approach. They harvest a anterior rectus myocutaneous flap. We go down, and then colorectal surgery mobilizes the rectum. OB-GYN did the hysterectomy, and then we go down, find the L5-S1 disc space, do the discectomy there, and then proceed inferiorly to the sacrectomy, localize the neuroforamen, and then at that point do a partial resection of the tumor, knowing you're going to come back the next day. And then on the ventral surface of that resection cavity, they put that myocutaneous flap. Sometimes they tag it so they can find it the next day. And then you come back the next day. She went to the ICU the first night. She was extubated. And then this was the MRI.
So which structure? You need the pen.
This was the MRI that was obtained after the first surgery, but before the second surgery. And so on the left, yeah, we're trying to find the pen on this screen.
Alexis, we cannot see the pen in here. See here. Okay, I can go back. You can use it.
So on the left, yeah, on the left you see the pre and post contrast images, and you see there is still contrast enhancement, more so on the left, and that's where we will come back to finish it. On the sagittal cuts, T1 contrast and post contrast, you see this myocutaneous flap being put just on the ventral surface, and with some residual tumor posteriorly that would be resected the next day. So essentially anterior approach, subtotal partial resection, hysterectomy, and then this flap that gets put ventrally and eventually found from the other side the next day. So the next day she was brought back to the OR. Again, plastic surgery, vascular surgery initially does the incision. They mobilize the paraspinal muscles to flap them down to the lower spinal wound. They preserve the pedicle, and this essentially gets put down to eliminate the dead space. At that point, we did excise the sacral biopsy tract as previously planned, just in case. And essentially, you definitely would do that in case of a chordoma. Then we proceeded to the tumor resection, finishing it off from the back for gross total resection. We did sacrifice some roots on the left side, which were completely encompassed by the tumor, but did preserve the sacral roots on the right side. And then that rectus abdominis myocutaneous flap that was put ventrally gets placed posteriorly, followed by screws L4 to ilium with 2 iliac bolts. So here you can see the intraoperative pictures. You can see the iliac bolts. Yep. The iliac bolts and the screws above, sorry, just above, and then at cross connectors. There you go. So you see this construct, iliac screws, screws above, and then the cross connectors to essentially provide a good base support for holding the entire spine that's rostral to it. And then you see the flap here. And then this is intraoperative x-rays, again demonstrating.
Show the skin in here. Part of the skin of the flap is right there. Show that.
And here, this is the flap that's was placed from the ventral surface. And then interestingly, you see the intraoperative images. You still have the onyx embolization. So it wasn't embolized intratumorally, just the feeders for the tumor, which did decrease blood loss. So coronal and sagittal x-rays intraoperative. I don't know if you want to add anything, Dr. Uribe, there.
No, that's fine.
And then, so this is the post-op, complete post-op pictures after the second stage surgery. You see no enhancement to suggest residual tumor. Let me get the pointer back. You see this flap. You see the, this thecal sac here, but no hyperintense T2 tumor left here anymore. So this, gross total resection based on the imaging and intraoperative findings. This is the CT post-op. You can see essentially a cercrectomy with 2 iliac bolts and hardware superior to that. So the patient was admitted to the ICU. She stayed in the ICU for about 6 days. For the first day, she remained intubated, lots of periorbital edema or pharyngeal edema just due to the length of surgery. She was extubated on post-op day 1. Foley was taken out. However, she did have some retention issues. So eventually urology placed a suprapubic catheter. Her strength improved over time. She was full strength. She was able to avoid her bowels. However, she did have the catheter upon discharge, but she was discharged ambulatory with a walker. And then you could see her skin healing up nicely here on her post-op visit. And then this is her here 8 months post-op. She is completely neurologically intact, full strength, no bowel or bladder issues anymore. Her suprapubic catheter was removed. She's wearing her brace. Otherwise, she's endorsing very minimal back and leg pain, significant improvement in the pain. Her incision was well healed. She's not using a walker anymore and just doing great. And partially that is because we did preserve all the roots on the right. And this is x-rays obtained at the 1-year follow-up. And you can see, hardware intact, no malalignment, no broken rods, no broken screws. She's feeling great. Back pain is minimal. Good sagittal balance. And then this is MRI 22 months post-op and on the right here. And you can see the significant difference. This is T2 images, essentially gross total resection of the tumor. And most importantly, she's doing great. She's having significant improvement in the pain, ambulating, and bowel and bladder is intact. And back to work. So with that, I think we both finished with the presentations and we'd open it to questions and discussion.
Juan, this is Izzy again.
Yes, sir.
Great reconstruction, great surgical technique, but what are you doing to hold up the spine over time? That doesn't, I'm worried that those rods are going to give way or the screws are going to loosen. Did you do any kind of reconstruction there or
yeah,
there?
Yeah, so what we do is, which is interesting, is first, you have to recognize that this is not en bloc resection. When you have en bloc resection, you have to reconstruct the entire pelvis, which is more challenging biomechanically, yeah? But if you saw in one of the CT cuts in there, still a lot of sacrum around it, the side joints are still there. So we are basically making sure that the rim of the pelvis is preserved. And then obviously we use as a proximal fixation points L4, and then we get to the pelvis. And then, this construct that you see there, we call the crab, it looks like a crab. And what we do is we build it out of different cross links. And the idea is to reconstruct at least the posterior arch of the pelvis again. And then, if you look at the traditional papers, which unfortunately they come on the early 2000s, and that at that time it was more limited, and that's the classic picture from the Hopkins drawing. Used to be the illustrator that used a piece of fibula with a bunch of perforation with wires, and then these screws coming in and out. And with the modern instrumentations, I will say, what we create is what I do that I've been actually having good outcomes. And you see this patient is already 2 years out and, tends to be working good, is we create this with a titanium mesh from one of the iliac screw to the other one. We create like a kind of a conduit, and then we put, commercial available graft, and then we expected that maybe closing the posterior wall of the pelvis. But, always a challenge, obviously. But I don't think if you can construct a better, you can build a better construct that using 2 iliac screws, and then trying to, share the load as much as possible. You tell me.
So Juan, there was no fusion. You just used the
we
metal.
put bone. No, we use.
Okay.
Yeah. No, we use bone. Yeah, definitely we use bone. And then, for example, in this case that the neurofibromas are benign lesions, we still use BMP, and that one, we think that can help us out, But definitely, the challenge with these ones is that you see, she's 25-year-old. She's going back to work. This pelvis is under a lot of stress. But again, don't forget that this is not a in-block resection. We still have some remnants of what stabilized the pelvis itself. Neil, you look very handsome on that picture.
Yeah, Neil actually asked a couple questions. Neil,
thank you, sir. No, Juan, thank you. Enjoyed the case. I agree with the construct. I'm certainly concerned about that construct and love to see a 3 to 5 year follow-up on this. I think at some point, I agree with Izzy and the others, that's going to fail. But beyond that, the pelvic floor, both the cases, can you talk to us? What do they do to the pelvic floor? There's nothing to connect the entire pelvic floor. So what do those guys do to keep that function going?
Yeah, I mean, there's the in terms of the pelvic floor.
Yes, the pelvic floor.
So the trick is, what I've been learning through the years, by facing, and I early in my career, working at the Moffitt Cancer Center in Tampa, we have significant of these kind of cases. I learned very early that once you decide to go front and back, the anterior rectus muscle myocutaneous flap is actually, I would say, to me, is most of the success in terms of preventing rectal hernias, pelvic floor, because what you do is you feel that big dead space that's going to be created by not having the sacrum anymore and not having anymore the tumor itself. It takes over that. And that's why it's so important, always leave that big bulk of muscle on the area where the tumor was. And I think that's what protects most of the time that Neil. But don't forget, this is a really good outcomes patient, these 2 of them. It is not the rule. A lot of times you still patients have sphincters issues and they get that's catheterization for the entire life. And but
right,
what
exactly.
I was trying to highlight today is like neurofibromas for being benign lesions, your goal is how can you make this the less morbid possible? Yeah.
Thank you.
So Juan, how many of these do you do a year?
No, this is very rare. You know, they come 1 or 2 per year. Best case scenario, you know, is I think in average maybe 1, 2 per year. They're very rare, you know, especially you know, sacral neurofibromas, you know, schwannomas. In general, sacral tumors is, I mean, we go from 2 a year to maybe 3 or 4, you know. And, you know, here at the Barrow, we have you know, a lot of talented surgeons. So it's not one person treated them. So it's spread amongst the other attendings, but still they're very rare. It's more common in places like, you know, Andy Anderson, like the big cancer centers, you know, Slow Kettering, Moffitt in Florida. But yeah, I'm not sure you guys at TBI have this type of pathologies or how you guys handle
We see one a week. No, I'm kidding. Izzy, I'll let Izzy answer that.
Yeah, we see them on occasion. I must admit the last couple big ones we've referred on because we just don't have.
We lost you, Lisa.
The multidisciplinary backup that you have there. Let me ask this one. Is there any role today for using spinal radiosurgery of some sort to treat these schwannomas?
With that size, that's the problem. You know, we just take it from the brain experience, you know, like acoustic neurinomas and that. Usually when the lesions are small, radiosurgery do that. The question is, I like it is, what happens if you don't do a subtotal, you know, total resection, if you will consider radiation after that. And I think based on also learning what we get on the brain, probably it's better to watch them because since, you know, like for example, the first case, what was the K10?
Less than like the replication index.
Yeah, you look at the replication index. Yeah, and as long as it's lower, doesn't make sense to take the risk of radiation. And the problem is, don't forget, the radiation, the pelvic area can be really bad. You know, that colonic radiation complications are really bad, you know. But obviously, when you deal with different, for example, another one that is, you know, obviously is not these cases, but what I learned on the last 4 or 5 years, the giant cell tumors, which used to become a very complicated tumors to remove, now you can do a pre-treatment with chemotherapy, and actually they can shrink a lot. It's amazing how we're changing, for example, the treatment of the giant cells. It's interesting, you know, they're very interesting pathologies, a very challenged area of the spine to manage. But fortunately or unfortunately, the volume is not there, so it's very hard for us to become experts on this. Yeah.
I can answer the thing about this is Jens Chapman about the radiosurgery. So we have a paper. It's published by Olinger, and this is around the spine, and this was with a gamma knife and. Or surgery. And again, what we basically found was that with the gamma knife, the tumors did not vanish. They kind of stayed. This is after 3-year follow-up with MRIs. And with surgery, they were gone. So I completely with Juan about the indication for surgery. The other factors that the S1 upper end plate, as well as the ala, looked very thin and hollowed out. So there's a structural indication. So I do think that radiosurgery for this kind of a lesion, this young lady had no role. Thank you.
I'm glad. Yeah, so that's pretty much. Not sure if there is more comments, but.
So one in both cases, you had sacrifice of multiple lower sacral roots unilaterally with preservation of bowel and bladder function. And that's what we used to see at Rancho with unilateral lower sacral trauma. And the old time guys all said that as long as you had one side preserved, you could lose the other side and still maintain bowel and bladder function. It's kind of interesting to see that in two out of two cases of
Yeah,
yours.
it was. And the second one, obviously, you know, we were telling the patient, you will never have sphincters control anymore. You know, we were expecting cutting everything from S2 distal, but every time I see this nerve root coming out, I just give them a try, you know, and see we can preserve them before upfront prophylactically sacrifice them. And then also, just for a personal experience, you know, when I moved from Florida to Arizona, first case that I did in here, the reaction of the colorectal surgeon was in here is like, let's take the rectum out. I'm like, wow. So you guys need to make sure that you protect your patients, you know, because these colorectal guys can be very aggressive. I'm like, no, listen, can we? And this woman ended up not even, you know, our patient not even with a colostomy. And they upfront, they tell you in the first meeting with them, like, oh, I think it's better to take this rectum out. So it's very interesting. So don't forget that we have to act also as the advocates and the captains of the ship when we put together these surgeries and protect them.
The key thing is, as you stressed, is you have to have a multidisciplinary team. You have to have all the people and all the resources focused. And this is not for the casual surgeon or the small community hospital surgeon, for sure.
Correct. Yeah.
Once again, Juan, great cases.
Thanks very much for the opportunity. You know, keep inviting us. We keep bringing some polemic things.
Will do. Thank you.
You never
guys.
disappoint.
Okay.
Solid work, guys. Have a good night.
Thank
Yes,
you.
thank you very much.
And all
Good
the
night.
participants.
Thank you.
Have a good one, guys. Thank you.
Take care.
Thank you.